The following podcast is part of a certified educational activity, Unraveling the Intricacies of HCC Management with Your Multidisciplinary Team, a closer look at effective selection and sequencing strategies in an expanding treatment landscape, featuring Amit Singhal, MD, MS from UT Southwestern Medical Center in Dallas, Texas, Anthony El-Khoury, MD from the USC Norris Comprehensive Cancer Center in Los Angeles, California, Robin K. Katie Kelly, MD from the UCSF Helen Diller Family Comprehensive Cancer Center in San Francisco, California, and Riyadh Salem, MD, MBA from the Northwestern University Feinberg School of Medicine in Chicago, Illinois. Access the entire activity and complete the post-test at peerview.com/CWP860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hello, and welcome to Unraveling the Intricacies of HCC Management with Your Multidisciplinary Team, a closer look at effective selection and sequencing strategies in an expanding treatment landscape. I'm Dr. Amit Singhal from UT Southwestern Medical Center in Dallas, and I'm joined by my colleagues Dr. Anthony El-Khoury from USC Norris Comprehensive Cancer Center in Los Angeles, Dr. Riyadh Salem from Northwestern University Feinberg School of Medicine in Chicago, and Dr. Katie Kelly from University of California in San Francisco. HCC is the fourth leading cause of cancer-related death worldwide, with the highest burden in East Asia and in Africa. Although it has a lower incidence here in the United States, we do see disturbing trends in terms of mortality over the last 15 years assessed by SEER. During this time period, you can see the mortality for most common cancers has decreased. We see increases in pancreas and brain cancer mortality. However, by far leading the way is liver cancer-related mortality, highlighting that we clearly need to do a better job in terms of advances in terms of early detection and therapeutics. Now, one of the unique things about HCC is that we have an identifiable patient population. Over 90% of HCC in the United States and Europe occurs in the setting of cirrhosis. And this cirrhosis, as many of you know, can happen from a host of different etiologies, with the most common ones being listed here on the slide. Of course, we have the traditional viral hepatitis, whether hepatitis C or hepatitis B. We have alcohol-related liver disease. And then we have an increasingly common cause of both cirrhosis and HCC, non-alcoholic steatohepatitis. Once somebody develops cirrhosis, we know that they have an annual risk of developing HCC somewhere between 2 to 3% per year. As we've made advances with viral hepatitis related to advances in terms of antiviral therapy and vaccination programs, and thereby reductions in both hepatitis B and hepatitis C related HCC, we've seen unfortunate increases in the other etiologies. And by far leading the way continues to be NASH-related HCC. Once again, an increasingly common cause of HCC in all of our clinical practices. This was a very nice modeling study that was published a couple of years ago, which shows that not only is it increasing now, but is anticipated to continue increasing over the next decade. Not only here in the United States and in Europe, but really worldwide. And this is going to be one of the most common causes of HCC as we move forward. Now, when we consider the broader treatment landscape, most of the talks that we're going to be hearing today are going to be focused on the advanced stage setting and the very exciting advances we've seen in terms of checkpoint inhibitor therapy, clearly providing significant improved survival both in the frontline and second-line setting for these patients. However, of course, it's important to consider the broader landscape of HCC therapy. And truly, the best prognosis for HCC continues to come around if we find people at an early stage, highlighting the importance of surveillance programs and early detection. And if you find somebody at an early stage, it's important to refer these patients for curative therapies. So refer these patients for a local ablation, surgical resection, and liver transplantation. These continue to be the only therapies that are associated with 5-year survival greater than 60 or 70%. So even though you're going to hear about a lot of the exciting advances in the later stages, once again, critical for all of us to remember that these are the curative therapies that continue to be available. The other thing that's important as we consider the BCLC treatment landscape is that the BCLC makes it seem like these are very clean buckets, BCLC-A, BCLC-B, BCLC-C, but anyone who treats HCC knows that this is often a continuum and that patients can often migrate from one stage to another and from one therapy to another. So, many of the talks you're going to hear about will talk about very exciting objective responses. And so we can see people with significant shrinkages in tumor, and you're going to be seeing people that actually go to the left-hand side. You're going to see people that go from the advanced stage to the intermediate stage, and the intermediate stage to the early stage. And so it's important for us to, once again, reconsider therapies in those patients as they have stage transitions. Likewise, there continue to be patients who have progressive disease, so patients who failed therapy. And this will be another concept we'll talk about over the next 90 minutes, where if patients fail therapies, there are other therapies that we need to consider and, once again, represented in our tumor boards. Overall, one of the key concepts that I'm hoping that you can take home today is that it's important that we work in a multidisciplinary team. Much like the panel here today, where we have hepatologists, interventional radiologists, and medical oncologists, this is really the epitome of a treatment team for HCC, where we need all of us to continue working together, along with many of our other colleagues, surgeons, pathologists, radiologists, radiation oncologists. And really, this team needs to come together and think of the best treatment for an HCC patient, not only at baseline, but as they go through their treatment journey. And this is really not only a nice concept, but as you can see here on the right-hand side of the slide, there are many studies that show significantly improved outcomes in a multidisciplinary format. So you can see that there's better treatment options that are delivered to the patient, there's more curative treatment options, and most notably, several studies have shown significantly improved survival when patients are provided multidisciplinary care. So with that, I'm going to hand it off to one of my colleagues to talk about the expanding portfolio of options for first-line treatment of advanced HCC. Katie?
Thank you so much, Amit, and thank you for having me to speak today on a very dynamic, changing playing field right now. As you said, our title for this section is Drawing from an Expanding Portfolio of First-Line Options. And I'll show here the latest NCCN guidelines, which, as one can see, show now a multitude of first-line treatment options. And if we look back in our mind's eye to how this slide would have looked even just 3 years ago, really there was only one option for, again, the preceding decade, which was sorafenib alone, followed by the second-line option of regorafenib in 2017. And since then, just an explosion of new treatment options that have really maximized our ability to select the right treatment for our individual patients. So one thing we'd like to highlight in this talk ahead is the fact, as shown here in the red star, that we now have immunotherapy options on the first-line treatment list here, including the recently approved regimen of atezolizumab plus bevacizumab for Child-Pugh A class patients only, but also nivolumab as monotherapy in patients who may not be eligible for some of these other options. And so I'll go through some of these, again, because it's been such a rapid change. So again, prior to the advent of immunotherapy in the first-line context, we first, for many years had just the option of sorafenib, which certainly did provide a meaningful survival benefit in both the SHARP trial in the Western population and the Asia-Pacific trial, improving survival in Child-Pugh A patients. And then more recently, the advent of lenvatinib in the REFLECT trial, which showed non-inferiority to sorafenib with respect to overall survival, but did improve substantially the secondary endpoints, including objective response rate, progression-free survival, and time to progression, and itself became a meaningful option in the advanced stage disease setting. Now, What's been quite an impactful change in this past year alone was the reporting of the phase 3 IMbrave 150 trial, first presented in its final results from the ESMO Asia presentation in late 2019 and published in the New England Journal in May of 2020. And here you can see the schema for this trial, which examined the combination of atezolizumab, a PD-L1 inhibitor, immunotherapy, plus the VEGF inhibitor antibody bevacizumab compared to the control arm of sorafenib. And a few key points from the patient population is that these were unresectable advanced patients, had no prior systemic therapy, ECOG 0 or 1. All of the patients had had a prior upper endoscopy within the preceding 6 months to rule out varices or other lesions at high risk for bleeding, noting the risk of bleeding from bevacizumab in earlier studies, and Child-Pugh A liver function. So from a total of a 480 patient planned sample size, we can see here that the dual primary endpoints of progression-free survival as well as overall survival showed significant improvement for the combination of atezolizumab plus bevacizumab, improving both the progression-free survival as well as overall survival at the time of reporting. Moreover, we can see here the objective response rate from the combination. Historically, with tyrosine kinase inhibitors alone, we've been used to not seeing particularly dramatic range of shrinkage in our patients' tumors, unfortunately. But with the advent of these immunotherapy combinations, we're now seeing, using RECIST 1.1 criteria, an objective response rate of 27% confirmed by central review from the atezolizumab bevacizumab regimen, or 33% when using the modified RECIST tool. Likewise, we're seeing some complete responses, 6% using central review by RECIST 1.1, and a duration of response that has not yet been reached. Again, one of the hallmarks of effective immunotherapy, that these responses are quite durable. So these objective response rates and other secondary endpoints really reinforce the progression-free survival and overall survival primary endpoint results of the IMbrave 150 atezo-bev regimen. Now, of course, safety is a critical endpoint in advanced HCC, particularly in an organ dysfunction population. And this slide shows here, again, that the safety outcomes of atezolizumab plus bevacizumab also compared favorably when placed side to side with sorafenib, with the dark bars showing grade 3 or higher events and the lighter bars showing all grade. And I think we can see visually that the outcomes of adverse events were greater overall for sorafenib. And when we look specifically at events of bleeding and other complications of atezo-bev, they were quite low and acceptable in this scheme of immunotherapy combinations. Reinforcing the safety profile of atezolizumab plus bevacizumab, we see the quality of life endpoint in this slide shows the deterioration in quality of life rather for the two treatment arms, and we show that while all of these patients have advanced cancer and did show a gradual decrement of their quality of life, this was slower and significantly decreased in the combination of atezolizumab plus bevacizumab over sorafenib alone. So again, underscoring that the safety was favorable by comparison to sorafenib and also recapitulated in the patient experience. Now, turning to a different first-line option, nivolumab monotherapy. The Checkmate 459 trial examined nivolumab versus sorafenib in the advanced HCC population, also first-line, shown here. And again, these patients were randomized 1-to-1 to nivolumab versus sorafenib. When we look at the overall survival presented at ESMO last year in 2019, we see that this was a negative study. There was not a significant difference in overall survival for sorafenib compared to nivolumab with a p-value of 0.7, hazard ratio of 0.85. But looking at landmark event rates of 12-month overall survival, there was an improvement for the nivolumab arm, likewise for 24 months, though small. I think looking also at some of the secondary endpoints, we can see that the health-related quality of life was favorable for nivolumab over sorafenib. And putting these together, along with the efficacy of nivolumab in the second-line setting, which Anthony will talk more about in a later section, I want to highlight here this box that the NCCN guidelines do consider the option of nivolumab as a reasonable choice in patients who are not eligible for first-line tyrosine kinase inhibitors or other anti-angiogenic agents such as the atezolizumab, bevacizumab regimen. And again, we can talk more about who those patients might be, but in patients who are not eligible for an anti-angiogenic option, nivolumab has shown these results that are supportive. Now, again, drawing from a page in the book in other tumor types, as well as following upon the atezolizumab plus bevacizumab experience, there are multiple other combination regimens under study in advanced HCC with the idea of harnessing this immune response and augmenting the likelihood of response from checkpoint inhibitors monotherapy. And so there are two general categories of combinations trying to do this. One of them are dual checkpoint inhibitor combinations, such as PD-1 or PD-L1 inhibitors combined with a CTLA-4 inhibitor, as we've seen have efficacy in other tumor types, particularly renal cell carcinoma and melanoma. And two large phase 3 trial examples of this are the Himalaya and Checkmate 9DW trials. And a different approach, following again upon the atezo-bev IMbrave 150 experience, is the combination of a checkpoint inhibitor immunotherapy plus tyrosine kinase inhibitors, which have anti-angiogenic targets, but also have other multi-kinase targets that may modulate the immune response and help promote an immune responsive microenvironment. And two important trials exemplifying this approach are the LEAP-002 and COSMIC-312 trials. So turning to the first group of combination approaches, the combination of CTLA-4 plus PD-1 or PD-L1 inhibition, we see here a schema of explaining the rationale for this approach, knowing particularly that CTLA-4 inhibition helps to prime T cells in the peripheral lymph nodes, allowing dendritic cells to present antigen and result in activation, while PD-1 or PD-L1 inhibition in the tumor microenvironment likewise helps to activate T cells more directly with tumor antigens. So one example of this combination of CTLA-4 inhibition with a PD-1 or PD-L1 inhibitor is the combination of tremelimumab, the CTLA-4 inhibitor, and durvalumab, a PD-L1 inhibitor. And shown here is the schema for a recently completed phase 2 trial, which was conducted predominantly in second-line patients, but included about a third to a quarter of patients who had refused prior sorafenib, so were actually first-line. And one can see here that there were 4 different treatment arms looking at 2 different approaches to CTLA-4 combination. One was a single higher dose priming dose approach, and the second arm was a repeated tremelimumab 75 milligram sequential dose, both combined with durvalumab, versus single-agent durvalumab versus single-agent tremelimumab. The primary endpoint was safety in this combination, with key secondary endpoints including objective response rate, duration of response, as well as biomarker correlates and overall survival. So if we look at the results from this 4-arm study, they're shown here. The overall survival outcomes in this Kaplan-Meier curve highlight that the 2 arms with the higher dose of tremelimumab, the tremelimumab alone and the T300 plus D arm, had the longest overall survival. And the T300 plus D priming arm was the best of the 4. This was also borne out in the objective response rate, with an objective response rate of 24% for the priming dose arm. And based on this phase 2 data, the phase 3 Himalaya trial was launched and has now completed enrollment. Also with 4 different comparative arms, durvalumab alone, 2 different combination arms, including the T300 plus D priming dose arm, and sorafenib as the control. And this was a first-line trial in advanced HCC patients that we can look forward to resulting in the near future. Now, another CTLA-4 inhibitor combination approach is the Checkmate 9DW trial, also in the first-line context, looking at first-line nivolumab plus a PD-1 inhibitor plus evolumab, which is a CTLA-4 inhibitor. And as you can see, this trial was randomized. Patients were randomized to nivolumab plus ipilimumab, the treatment arm, versus sorafenib or lenvatinib according to physician choice. And this trial is still ongoing, and Anthony will present more data on the combination of nivo plus ipi in the second-line setting, which again led to the development of this phase 3 first-line trial. So again, here's a summary of the strategies. I just talked about the PD-1 or PD-L1 inhibitor plus CTLA-4 combinations. Next are the immunotherapy plus tyrosine kinase inhibitors as a different strategy. So one such trial, which has also completed enrollment and we're looking forward to its reporting, is the combination of cabozantinib, a multi-kinase inhibitor, which we know has a role in the second-line or third-line treatment setting, but itself also has some immunomodulatory properties as well as being an anti-angiogenic agent. combining that with the PD-L1 inhibitor atezolizumab versus the control arm of sorafenib. So this trial is entitled Cosmic 312 and looks at the cabo plus atezo combination arm versus cabozantinib alone versus sorafenib alone in advanced first-line HCC patients. Again, based on the premise that the cabozantinib multikinase inhibition of some of these immune modulatory targets, as well as its anti-angiogenic therapy, may promote an immune response in combination with atezolizumab. Another really important combination on the horizon is the multikinase inhibitor lenvatinib combined with the PD-1 inhibitor pembrolizumab. This combination has already reported results from a phase 1b study, including over 100 patients at ASCO 2020, and showed a quite striking objective response rate of 36% for the combination using RECIST version 1.1 in a first-line advanced HCC population. These responses were durable, and the disease control rate was also quite high at 88%. And this combination efficacy in the phase 1b context has led to the phase 3 LEAP-002 trial, which is examining the combination again of lenvatinib plus pembrolizumab versus lenvatinib alone. And this trial has also completed enrollment and is another exciting data point on the horizon that could change our first-line play or expand our first-line playing field further. Here is a table showing a host of other trials in development or ongoing, showing again that the combination of immunotherapy with other partners, including anti-angiogenic agents such as this VEGF monoclonal antibody or multikinase inhibitors, are of great interest in hopes of further harnessing the immune response and augmenting response rates and durability and long-term outcomes. So with that brings us to our first case, which I'll start to present. So this is a 62-year-old man with untreated, newly diagnosed chronic hepatitis B virus. At the time of presentation, again, he had not been treated in the past for hepatitis B, so unfortunately he had active transaminitis with AST and ALT in the 200s, a very elevated hepatitis B viral load, but otherwise preserved liver function with normal bilirubin and albumin. He had some early symptoms or signs of portal hypertension with a grade 1 thrombocytopenia. Platelets were only around 100, and his AFP was very elevated at 9,000 nanograms per milliliter. That said, he was quite fit, working full-time, ECOG score of 0. An MRI scan for this patient ended up showing multifocal HCC, which was LIRADS 5, diagnostic for HCC by radiographic criteria, including 4 lesions, one of which was quite large, 5.6 centimeters, infiltrative and invading into the right portal vein. He also had some, again, signs of portal hypertension with splenomegaly, hepatic nodularity. So I guess the first question for my colleagues is a biopsy needed in a patient like this? And then next we can talk about management.
So maybe I can start, Kelly. I'll just chime in real quick. And for me, from a radiologic standpoint, LIRADS 5 is pretty much diagnostic arterial enhancement with venous washout. That's the first thing. And the second thing is, it's very characteristic for HCC, even though some cholangio HCCs can do it, but mostly HCCs will invade into the portal vein. So from an imaging standpoint, this looks characteristic for HCC.
So in this case, we ended up not biopsying him. I'll add this was right at the beginning of the COVID pandemic, and we were trying to avoid procedures and felt this was diagnostic, as Dr. Salem alluded to. So in terms of the next step in his management, we referred him to a hepatologist. He started an antiviral for his active hepatitis B and had pretty quick improvement in his transaminase elevation and decline in hepatitis B viral load over the next month or so. And in parallel, had an upper endoscopy, which was clear, no sign of any varices. So then, being his oncologist, I presented him several options, including the standard of care regimen now based on IMbrave 150, which is the combination of atezolizumab plus bevacizumab, as we saw in the very first NCCN guidelines slide. And we also talked about clinical trial options, including first-line immunotherapy combination with either a TKI or a CTLA-4 inhibitor.
So thanks, Katie. That was an excellent talk and really took us all through the amazing progress that we've made over the last couple of years in the frontline setting. Quite an exciting time to be managing HCC. It looks like we have a couple questions that have come in from the audience. So as you went through this case, it looks like this patient did not have varices. But if you had done the upper endoscopy and you had seen, medium to large varices, what would you have offered him?
So that's a great question. I think if my hepatology colleagues had said we're really worried about this patient's varices and needed to do serial banding, I would have strongly considered lenvatinib or sorafenib, noting that they do have lower bleeding risks than bevacizumab-based regimens, at least cross-trial comparison-wise. And if the patient had really frank contraindication to anti-angiogenic therapy, this is the type of situation where I would consider evolumab alone as monotherapy.
Yeah, Anthony, anything else that you would consider in that setting?
No, I agree, but I would just note that if the varices are treatable, the patient would still be eligible for atezo-bev. At least those were the eligibility criteria for the study. The treatment of varices was left up to the treating physician at the institution where the patient was enrolled. So I agree that if serial banding is required, that raises the risk of bleeding. So I agree with Katie, but if it's a matter of just banding a few varices and maybe doing a follow-up surveillance EGD, I think atezo-bev could still be an option in that case.
Okay. So it seems like, both of you would try to get the patient on atezo-bev, but if not, then sorafenib and lenvatinib still do have a role in some patients in the frontline setting. And as Katie said, nivo can also be considered if the patient can't receive any TKI therapy. So let me ask you, this patient was very well compensated Child-Pugh A. What would you have done if he had more severe liver dysfunction? What if he was a Child-Pugh B when he presented?
Yeah, that's another great question. I think we need prospective data for that population in particular. I will say from my own current practice, it depends in part on what kind of Child-Pugh B. If it's a patient that's really on the border between Child-Pugh A6 or B7, depending on the albumin on a given day, and has been very stable for a long time without signs of active decompensation, I'm inclined to use a Child-Pugh A regimen with careful discussion and close monitoring, even atezo-bev, if the EGD is negative and there's no bleeding risk. Now, on the other hand, if it's a Child-Pugh B8 and a patient is really evolving with early ascites or other signs of decompensation actively, I'm more inclined to use either sorafenib, for which we do have some prospective safety data in Child-Pugh B, or nivolumab.
Okay. And the final question that came in is, the IMbrave 150 excluded patients with significant thrombocytopenia, excluded patients with daily NSAIDs, and as you mentioned, required an EGD within 6 months for all patients. How are you operationalizing these criteria for your patients you see? And are there any patients that you would say, I don't think he needs an EGD?
Well, this is a case that really or question that really exemplifies the importance of multidisciplinary management, because I generally talk with my hepatology colleagues about these types of patient on a case-by-case basis. And if patient had an EGD a year or two ago, has no stigmata of portal hypertension, normal platelets, normal spleen, no radiographic varices, which admittedly are not a surrogate for endoscopic varices, but no other symptoms or signs of portal hypertension, and our hepatologists think they don't need an endoscopy, I'm willing to proceed with careful monitoring. On the other hand, if a patient has low platelets, it's not so much the platelet count itself, but the fact that that's a sign of portal hypertension, and that makes me more concerned and feel that the endoscopy is merited.
Anthony, anything that you do differently in your practice?
Oh, I fully agree with that approach.
Okay, perfect. Well, thank you, Katie, for taking us through that. Once again, quite exciting to see all the progress that we've made in the frontline setting. And with that, we can move to the second line setting. So, continuing the case that Katie started, once again, we had the 62-year-old male with hepatitis B cirrhosis who was found to have advanced HCC and who was started on, once again, atezolizumab and bevacizumab in the frontline setting. While he was on this combination therapy, he did quite well, but did have one episode of grade 2 immune-mediated hepatitis. The checkpoint inhibitors were held, and he was treated with steroids at that time. He was then able to restart the therapy and did well until about 8 months later, when he was noted to have disease progression with new metastases noted on imaging. At the time of disease progression, he remained Child-Pugh A, continued to have good performance status, and his AFP was 217. So I'd like to ask my colleagues on the panel what they would consider in this case in the second line setting in this patient who had progression on atezo-bev. Anthony, why don't we start with you? What would you consider in a patient like this?
So, certainly there is currently an absence of level 1 evidence for specific second-line therapies because all of our second-line treatments were evaluated in the post-sorafenib era. So with that in mind, certainly what we've done is extrapolate from existing experience and have been using second-line or second and third-line agents in this space. So TKIs would be a possibility. Cabozantinib certainly is a very reasonable option. Regorafenib is an option. However, the data for regorafenib is really very specific for post-sorafenib with specific requirements for tolerability in first line. So, that's something to consider. Certainly in practice, we've seen sorafenib and lenvatinib being used as well in the second line space. It's hard to say whether that's right or wrong. They have a different mechanism of action and certainly could be active post-atezo-bev. Certainly, I would not use an anti-PD-1 or anti-PD-L1 agent alone in this space. The big question then becomes whether to use the combination of nivo and ipi. Certainly I would say again, there is no data currently about the efficacy of nivo-ipi and safety of nivo-ipi post-atezo-bev. Certainly one could say, well, it's the same way that we're using the TKIs without data. One could use nivo-ipi in someone with good performance status and well-preserved liver function. However, here I would worry a little bit about the prior grade 2 immune-mediated hepatitis, given the fact that nivo-ipi has a higher chance of immune-mediated adverse events. So I would gravitate more towards the TKIs in this situation. Sorry for the long answer.
No, that was great. I think it was a very nice way to summarize actually the expanding landscape of options we have. And I think with that, we can now go through some of the data we have to help inform these decisions. This is a slide that, once again, we started with in terms of showing the multiple options that we have not only in the first line, but also it's been exciting because we've had multiple agents now come into the second line as potential treatment options. Once again, a huge advance from where we were just even a couple of years ago. When we think of the second line treatment options, as Anthony mentioned, most of these, if not all of these, have been evaluated after sorafenib frontline, and so they've really been evaluated after TKI-based therapy. However, as you heard from Katie, the landscape for the first line has completely changed, and we live in a world where immunotherapy now predominates on the front line. And so, as we'll talk about, the big question is can we take these data and extrapolate them to a patient who has received atezo-bev or other agents in the frontline setting? So this really, once again, has changed the entire treatment paradigm, where we see IO therapy being the preferred frontline therapy, and we see TKIs and combinations such as nivo-ipi really being now largely restricted to the second line setting for many of these patients. Once again, you've heard from Katie the data from both the SHARP trial as well as the REFLECT trial. The data, bringing sorafenib and lenvatinib into the frontline setting. And as you heard from Anthony, now that patients receive atezo-bev in the frontline setting, many of us have started to consider sorafenib and lenvatinib in some of those patients who may have disease progression on atezo-bev. So these agents are now at least being considered in selected patients, even in the second line setting, although the data don't exist in that line. In terms of other agents that do have approval currently in the second line setting, we do have data from the RESOURCE trial, which was the registration trial which brought regorafenib to the market. This was a randomized control trial that evaluated regorafenib versus placebo in patients who progressed on sorafenib. Once again, as mentioned by Anthony, the RESOURCE trial required people to be tolerant of sorafenib. So it was one of the key treatment selections to actually come onto the trial. So patients had to be on a dose of at least 400 milligrams a day for 20 of the last 28 days to get into the clinical trial. Now, many of us don't use that exact criteria, but I think many of us use the idea of this, that given the similarity in structure between regorafenib and sorafenib, I think many of us are at least relieved if somebody has shown this tolerance to sorafenib prior to considering regorafenib. In the resource trial, you see that regorafenib did have significant improvement in overall survival, with a median overall survival of 10.6 months versus 7.8 months. And you see from the hazard ratio a 37% reduction in mortality. Now that regorafenib has been on market for the last couple of years, we are starting to see post-marketing data that has been presented. And so this is data from the REFINE study, which shows real-world evidence of regorafenib in patients. And I think, in short, what you can see from the REFINE trial data is that you can see that regorafenib AEs appear very similar to what you see in the resource trial. And if anything, the AEs in clinical practice appeared lower than those reported in the resource trial. Similarly, when you take a look at the median overall survival for patients who were treated with regorafenib, we were relieved to see once again that efficacy observed in the resource trial does appear to translate into effectiveness when applied to clinical practice. So well tolerated in clinical practice, and you see similar survival when applied in clinical practice. Cabozantinib is another agent that's been approved in the second-line setting. This was approved based on the phase 3 Celestial trial, published a couple of years ago in the New England Journal. One of the unique things about this clinical trial is that it not only included people who had one prior line of therapy, but also included about 25% of people who had 2 prior lines of therapy. So really evaluated cabozantinib not only in a second-line setting, but also a third-line setting. And when you take a look at this and compare it to the other second-line clinical trials, I think one of the things that really stands out to me is the broad range of eligibility, the broad range of patients that were allowed into the Celestial trial. Patients were randomized to cabozantinib at a dose of 60 milligrams a day or placebo, and you see that cabozantinib significantly improved overall survival in both the second-line and third-line settings, with a median overall survival of 10.2 months versus 8 months for placebo, once again a 34% reduction in mortality. One of the nice things that was presented at ILCA, the International Liver Cancer Association, earlier this year, was some limited data for cabozantinib in Child-Pugh B patients. And when you take a look at its small numbers, but there are some data in Child-Pugh B patients where cabozantinib similarly showed a survival benefit in Child-Pugh B patients compared to placebo. This was a very nice analysis done by Katie when actually doing a matching adjusted indirect comparison of cabozantinib and regorafenib. I think, when you've heard any of us talk before, we always warn against just taking a look at overall survival and doing cross-trial comparisons. But if you're going to do that, this is actually the correct way to do that. So this was actually a matching adjusted comparison of cabozantinib and regorafenib, so adjusting for some of the differences in the clinical trials and the patient populations. And so by doing this, the investigators found no significant difference in overall survival between the Celestial and Resource trial, or between cabozantinib and regorafenib, although there was notable differences in progression-free survival. So there was a significantly longer progression-free survival for cabozantinib versus regorafenib when you do this sophisticated analysis of comparisons between the two drugs. The third agent, immunotherapy agent that's been evaluated in terms of second-line agents is ramucirumab. So ramucirumab was originally evaluated in the REACH trial. The REACH trial took all-comer second-line patients, so patients who had either progressed or intolerant of sorafenib. But in that trial, ramucirumab failed to show a benefit versus placebo. In a secondary analysis or subgroup analyses, the investigators did find that ramucirumab appeared to be of benefit in those patients with an elevated AFP at baseline. And so the nice thing is that the investigators actually did a full new registration trial. So they did a completely new randomized control trial, REACH-2, where they then once again randomized people with an elevated AFP at baseline greater than 400 nanograms per milliliter, randomized them to ramucirumab versus placebo, and in that REACH-2 trial demonstrated a significant benefit of ramucirumab versus placebo. Here you can see a combined analysis of patients both from the REACH as well as REACH-2 trial among those with an AFP greater than 400. And once again, you can see significant benefit of ramucirumab, median survival 8.1 months versus 5 months with a hazard ratio of 0.69. So in summary, I think we've seen a lot of advances in the second line setting, compared to 3 years ago where we had no agents in the second line setting. We now have multiple agents that have come through. So for patients like this that get treated with a very effective frontline setting, the nice thing is that we do have something in our back pocket. So now going back to the case that we started with, once again, our patient with hepatitis B cirrhosis, advanced HCC, treated with atezo-bev, grade 2 immune-mediated hepatitis, and then was found to have progression. You see here good liver function, good performance status, but the AFP is low. It's less than 400 nanograms per milliliter. So, Anthony started by giving us a very nice overview of his approach to this patient. Katie, what would you think in terms of, after hearing, the data for all these agents, what would be the choice if you were to see this patient?
So I tend to be in the camp, as you alluded to, of moving some of our previous first-line TKIs down into the second-line register. So I would probably consider lenvatinib in a patient like this as my next line of therapy. Yeah.
And so it seems like, both you and Anthony, it seems like, in this patient lean towards lenvatinib, and I think that's a very reasonable option. I tend myself to have that same big box of different options in the second line setting where you can consider sorafenib, lenvatinib, or these other agents that I discussed in terms of the second line therapies. But really, I don't think that any of those would be wrong. You could consider sorafenib, lenvatinib, or I think consider cabozantinib, and I think all of those would be very reasonable options. And I think it would really be a discussion with the patient in this case. In this case, we chose cabozantinib, and the patient has done quite fine quite well on the therapy. So with that, I would really like to hand it over to one of my other colleagues, Anthony, to really discuss, the role of immunotherapy in the second line and beyond. Once again, another area where we've seen a lot of advances. Anthony?
Thank you, Amit. So here we will talk about the role of immunotherapy in second line and beyond. Of course, this conversation has to be taken in the context of the bigger role or the dominant role that immunotherapy has taken in first-line therapy, as Katie showed us earlier. So let's start with reviewing a case. This is a 58-year-old Asian female with chronic hepatitis B. She is on antiviral therapy. This detail is not on here, and her hepatitis B level is suppressed. It's below 100. She presented actually with pain, and an MRI showed an 8-centimeter right lobe tumor, LIRAT5 with 2 satellite lesions and portal vein tumor thrombus, liver function well preserved at Child-Pugh, good performance status, AFP of 102, and she was treated with sorafenib and progressed. So second line options for considerations here, as far as immunotherapy, second line options would be nivolumab, pembrolizumab, or nivo in combination with ipilimumab. So let's review the data to support such an approach. This is to take you back to the design of the Checkmate 040 trial, which has multiple cohorts embedded within this phase 1/2 study. So here to the left, we see the nivo single agent cohort, which led to the accelerated approval, which we will review first. And then later we will review the data on the nivolumab activity in Child-Pugh patients and the nivo plus ipi combination as well. So starting with nivolumab single agent, this slide is meant to show that the activity of nivolumab was noticed across 4 different expansion cohorts: uninfected sorafenib naive patients, uninfected patients who had progression or intolerance to prior sorafenib, hepatitis C infected patients, and hepatitis B infected patients. So these were the 4 expansion cohorts, and you see responses ranging between 14 and 23% across these cohorts independent of etiology. What was important here and highlighted in these spider plots is the durability of the responses as well, with a median duration of response of almost 10 months. And when you look at specific subgroups, it actually is even longer for some of these subgroups. So the response rate as well as the durability of the responses at that time led to the accelerated approval of nivolumab after failure of sorafenib. We've also all gotten accustomed to see these long-lasting responses with PD-1, anti-PD-1 agents, which is highlighted in this slide from Checkmate 040, where the line in blue, in light blue, represents the patient who had an objective response, so PR or CR. And you see that the responses, again, are durable, but they translate into prolonged survival. So the median OS is not reached for the responders here, compared to 16.7 month median OS for patients with stable disease and shorter for the progressors naturally. And what's striking here is an OS of slightly over 90% at 24 months for the responders. What about the role of anti-PD-1 agents, especially nivolumab, where there is the data in Child-Pugh patients? As we've alluded to in this presentation today, that there's an unmet need for prospective data in patients with Child-Pugh HCC. This is a challenging group of patients because of their heterogeneity within the Child-Pugh status. But we've also known that Child-Pugh is associated with worse prognosis than Child-Pugh. I always tell my patients that their prognosis is determined by both the cancer as well as the underlying liver cirrhosis and the degree of cirrhosis. With that in mind, the historical overall survival for patients with advanced HCC and Child-Pugh status from prior registries with sorafenib was reported to be around 4 months. So as we mentioned earlier, there was a cohort of Child-Pugh patients in the Checkmate 040 trial. And this was a cohort of Child-Pugh 7 and 8, so no B9 patients. All these patients were required not to have had active hepatic encephalopathy or have required a therapeutic paracentesis within 6 months of enrollment. So, it is a subset of Child-Pugh patients that are well selected. They could have been sorafenib naive or intolerant or progressors, and they were treated with nivolumab every 2 weeks, with a primary endpoint of response rate and multiple secondary endpoints, including safety. And here we see the results from the Child-Pugh cohort, 49 patients in total, if you look at the third column here, and you see the objective response rate of 12%. So this is not far off from the 14.3% response rate post-sorafenib in Child-Pugh, which led to the accelerated approval of nivolumab. Now, if we compare it to all the expansion cohorts in Checkmate 040, where the overall response rate was 20%, this appeared to be a bit lower, but certainly, again, this is not a direct comparison, and the numbers for the Child-Pugh cohort are smaller. The responses were durable, again, with a median duration of 9.9 months. The types and the frequency of treatment-related adverse events were not different overall in the Child-Pugh cohort, except there was a slightly higher frequency of hepatic-related treatment adverse events or treatment-emergent adverse events. Part of that may have been driven by, again, the underlying cirrhosis. The median OS here was 7.6 months, which again compares favorably to the historical data that we have from the registries. What about the other agent, pembrolizumab, the other anti-PD-1 antibody? This is the summary of the phase 2 study, Keynote 224, with pembrolizumab as a single agent post-sorafenib, where we see an objective response rate of 17%, and really data that is quite similar to evolumab, which again resulted in the accelerated approval of pembrolizumab post-sorafenib. The challenge came in the phase 3 trial, Keynote 240, which randomized 413 patients post-sorafenib to pembrolizumab or placebo in a 2-to-1 fashion. This study had co-primary endpoints of OS and PFS, and there was a pre-specified p-value of 0.0174 required for statistical significance for a couple of reasons. One is that there were co-primary endpoints, and the study had designed to have multiple looks at the data, which consumed some of the power of the study. Now here we see the overall survival curves, where there is nice separation of these curves, with a median OS of almost 14 months with pembrolizumab and almost 11 months with placebo, a hazard ratio of 0.78, and a p-value again of 0.02, which if we had not looked at the pre-specified p-value would have thought is a statistically significant difference. But again, given this pre-specified p-value, this was not a statistically significantly positive difference. So there was clinical activity for pembro, but the trial was by definition negative and did not reach its pre-specified primary endpoint. Now, part of the challenge, in addition to the statistics and the design of the study, were the post-progression therapies that occurred, especially on the control arm of placebo, where a proportion of patients went on to receive anti-PD-1 therapy. So there were multiple analyses, sensitivity analyses shown here, which were exploratory in nature to look at the impact of post-treatment anti-cancer therapy on OS. And when these analyses were performed, you see that the p-value here becomes positive and the hazard ratio becomes even more favorable for pembrolizumab. So in summary, both nivolumab and pembrolizumab have shown clinical activity in second line post-sorafenib. I would like to remind the audience that the Checkmate 040 trial did not specify that patients have to be in second line. Some of them actually were third line patients as well. But nonetheless, both agents have activity in this space with consistent response rates and durable responses. We already talked about the challenge of the Keynote 240 study, which did not reach statistical significance. And similarly, as Katie had shared earlier, the confirmatory trial for nivolumab in first line, in comparison to sorafenib, did not reach statistical significance either. Now we review the last cohort of interest for this session, which is the combination of nivo plus ipi. So this cohort looked at 3 different schedules and doses of nivo-ipi. Arm A with nivo 1 milligrams, ipi 3 milligrams every 3 weeks, followed by nivo maintenance. Arm B, nivo 3 milligrams, ipi 1 every 3 weeks for 4 doses, followed by nivo maintenance. And Arm C is nivo 3 milligrams, ipi 1 milligram, but every 6 weeks continuously. And the primary endpoint here was safety, tolerability, as well as response rate. Here we see across all these cohorts of nivo-ipi a consistent response rate by RECIST 1.1 of 31 to 32%. I'd like to draw your attention to the 8% CR rate in Arm A with nivo 1 ipi 3 and a disease control rate of 54%. And again, the long durable responses with a median duration of response between 17 and 22 months. Now, when looking at median overall survival, Arm A with nivo 1 ipi 3 had a median OS of almost 23 months, versus arm B and C, where the median OS was 12.5 and 12.7 months respectively. So based on the aggregate of this data, the arm A Nivo 1 IP3 regimen received accelerated approval by the FDA post-sorafenib. And again, this is showing the data for the arm A, the survival specifically. And what's really intriguing is this OS rate of 44% through 30 months in second line with this combination. Of course, with the right patient selection. These were Child-Pugh E patients with well-preserved, Child-Pugh A patients with preserved performance status. And again, the responders tend to do very well with prolonged survival as seen here, compared to the patients with stable disease and progressive disease. There are some concerns about the toxicity of this combination naturally. So the median number of doses of Nivo and Ipi was 4 across the arm A patients. And all 4 doses of ipilimumab were completed by the majority, 67% of patients in arm A. The majority of patients discontinued for disease progression, with about 22% discontinuing for drug toxicity. Here's a summary of adverse events, treatment-related adverse events by category. I draw your attention to the category called investigations, which includes most of the liver abnormalities, with 33% grade 3 and 4 events. And specifically looking at hepatobiliary abnormalities, it was 6% grade 3 and 4. When looking at specific hepatic investigations and the category of hepatobiliary adverse events, we see that 33% of patients had a grade 3 or 4 abnormality of liver function of some sort. Now, most of these were either self-limited or responded well to steroids, with a reasonable proportion of patients being rechallenged, which was over 50%, by the way. This is a summary of the immune-mediated adverse events. If we look at any grade events, rash followed by hepatitis, adrenal insufficiency, colitis, pneumonitis, and nephritis were the most common. And when we look at grade 3 and 4, we see that rash and hepatitis were the 2 most common ones. 57% of patients required corticosteroids for immune-mediated adverse events. Now, some of these were lower dose corticosteroids, but in the aggregate, more than half the patients required some corticosteroid intervention for immune-mediated events. So with that in mind, we'll go back to the selection of immunotherapy option discussion that we had talked about earlier. So, post-sorafenib, at least this is when this patient was treated in the age of sorafenib as first-line therapy, we tend to gravitate towards immunotherapy, anti-PD-1 agents in second line for patients who have not received immunotherapy in first line. One reason for doing that is that we know if the patient has a response, it tends to be durable and quite impactful. So we'd like to give them a chance of having immunotherapy at some point. Now, this doesn't mean that the TKI sequence is wrong. Of course, there's level 1 evidence from going from one TKI to the next. But certainly this is a consideration to keep in mind. Of course, if there's rapid progression or intolerance of TKI in first line, immunotherapy would be definitely a reasonable option. If there is increasing degree of hepatic dysfunction, meaning the patient's liver function is deteriorating, going towards the Child-Pugh B, I think there is very reasonable rationale, strong rationale to actually use nivolumab in that space based on the prospective data from Checkmate 040. And lastly, if there are contraindications to TKIs and anti-angiogenic therapy in general. Thank you.
Thanks, Anthony, for taking us through that. Once again, quite exciting to hear. It looks like we do have one question that came in from the audience. And so, the case you presented was somebody who was on sorafenib frontline, and you were talking about the role of immunotherapy in the second line for that patient. But let's say this patient had presented more recently and had received atezo-bev. I think you had previously mentioned, single agent Nivo and Pembro doesn't quite make sense after atezo-bev because they've already received, atezolizumab in the front line. But would you consider nivo-ipi? Would you consider adding in a CTLA-4 type therapy to rescue this?
So of course, I'd like to again say that the nivo-ipi data, which is promising, is phase 1/2 data from Checkmate 040, and it's all post-sorafenib. The majority of patients were post-sorafenib. So we don't really have data post-atezo-bev, but one could consider the nivo-ipi combination based on extrapolation the same way we are using TKIs without data post-atezo-bev. But I would do it only in select patients, meaning patients who really have preserved liver function, who've tolerated the immunotherapy in first line well, and have a strong performance status, patients in whom achieving a CR or a deep response may be impactful clinically. So one could consider this, but again, without the presence of prospective data, which would be beneficial if we can get it. Of note is that there is some precedence for this in other solid tumors like melanoma, and there's emerging data in other tumor types that shows the efficacy of nivo-ipi post single agent PD-1, at least in first line. So there may be a precedent for this in other tumor types which would lend some rationale. So it's an option, but I say that with caution and with the right patient selection.
Yeah, I think, when we take a look at the last three talks, we've seen a lot of advances in each of these areas, first line and second line, though it's created a lot of questions as well. I think that's the way that I think about this. And unfortunately, we don't have great biomarkers to choose between these different therapies. And so hopefully that will be one of the other areas that we tackle over the next couple of years, is really trying to find treatment selection biomarkers that'll help determine who should be treated with IO therapy, who should be treated with TKI therapy. And as we have more combos, how do you choose between them? So with more choices come more dilemmas, I think. Thanks again, Anthony. That was excellent. Really, once again, really exciting to hear. And with that, we will go to the last segment that we have. And I'm going to hand it over to one of my other colleagues, Riyad, who's going to be talking about striving for continuous improvement in outcomes through current and emerging multimodal strategies. Riyad?
Thank you, Amit. Thanks for the opportunity to present here. And it's nice to have heard about a lot of the advances in advanced HCC. There's obviously a lot to discuss in the early and the intermediate stage for the treatment of HCC, and that's what I'll try to share with you today. So just to start off with a quick case, this is a 59-year-old patient with non-alcoholic steatohepatitis with good liver functions, found to have an incidental liver mass on imaging, 6.5, 7 centimeters with a few satellites, no PVT, no vascular invasion, no metastatic disease, and good liver functions, performance status 0. So just very quickly, maybe start with Dr. Singhal. This is an intermediate patient. What is your standard treatment for intermediate HCC at your center?
Yeah, this is somebody who we would be aggressive with local regional therapy. We've seen, obviously, chemoembolization used to be the traditional local regional therapy. Largely based on your data, we've started to see more and more radioembolization. And so this is probably somebody we would consider radioembolization as our frontline therapy.
Okay. So let's talk about what the guidelines say when it comes to intermediate HCC. And certainly the worldwide gold standard is chemoembolization. This is well delineated in the AASLD guidelines. And with level 1 evidence and with slightly lower evidence is radioembolization and the concept of trying to downstage intermediate patients to resection or transplantation. More specifically, when you look at what the guidelines say, they do talk about chemoembolization having the highest level of evidence with a strong strength of recommendation, and other types of local regional therapies practiced locally in certain settings, but having a lower level of evidence, but certainly being able to select based on specific patient criteria. How do patients do with chemoembolization? There is a manuscript, a study that was published a few years ago on 1,600 patients or so, the 6 and 12 prognostic score, which is of interest, where they developed a linear predictor where they would add the largest tumor diameter with the largest number. And based on this, you could see 3 groups that were created and a better survival with the lower number. As you can see here, less than 6, 49 months, going to 16 months if it's over 12. So this is a way that you can look at a patient and see how well they're going to do with chemoembolization in intermediate. And frankly, you use this tool to see whether there's a possibility or an option that if the patient is not going to do very well with chemoembolization, you could transition him, as Dr. Singhal was talking about, to systemic therapy even earlier if they're not a good candidate for this type of therapy. There are other things and other types of treatments that are on the horizon being developed. External radiotherapy, SBRT, is certainly one of them. This is a retrospective study looking at chemoembolization and SBRT. Not exactly an identical group of patients, where the SBRT group had smaller tumors and the chemoembolization group had more active disease, but basically showing that at least you're able to achieve good local control when you look at the SBRT group. Compared to chemoembolization. And some of that can be patient selection, where the location of the tumor is, the blood supply, etc. There are distinctly different treatments, but you can see here that there's some early work now differentiating and applying external radiotherapy to patients with intermediate, if not smaller, type disease. So where does that take us? We know the relationship between hypoxia and angiogenesis. When you have central necrotic tumors, or when you induce hypoxia with, say, embolization or chemoembolization, HIF-1 alpha is hyperexpressed, etc. And so this interaction and that relationship provides the rationale for things like TKIs, where potentially after the embolic insult, are we able to downregulate that response to improve either imaging or overall survival outcomes. This has been studied, so even though there is a rationale to add, for example, TKIs to chemoembolization, this has been studied in multiple studies, as you can see here, with the post-TACE, the BRISK, SPACE, Oriental, and TACE-2. In none of the studies were they able to demonstrate an improvement in overall survival. There are some that showed an imaging improvement, but that did not translate to overall survival. Most recently, the TACTICS study was recently reported on and in fact published in August in Gut, where they demonstrated a significantly improved progression-free survival when you add sorafenib to chemoembolization, except that PFS was not the classic PFS, but rather time to untreatable progression, this novel endpoint that tries to parallel or mimic what we see clinically and showed that basically when you add sorafenib, that endpoint, that novel endpoint, is achieved much later. What's on the horizon? What's next? I think the obvious thing based on the first 3 speakers that you saw is combining local regional therapies with immunotherapy. The hot topics are things like, do you need complete necrosis? Do you need to treat all of the lesions? Do you need to ablate or radiate or embolize? Which is able to cause increased immunogenicity of the tumor and cause that response. You can see an image on the right-hand side of a large lesion that was treated with combination type treatment. So really very promising type outcomes. But what is the optimal timing is the other sort of unknown. Do you do the immunotherapy first, the local regional therapy first? Do you do them simultaneously? So there's a lot of work that's being done in this, all of which is really to chase the abscopal effect, the fact that you're going to treat one area and another area is going to respond. As Dr. Singhal mentioned before, we don't have biomarkers to predict response, and so it makes this particularly challenging. What do we know? Has there been anything published? Dr. Pignatto published this at ESMO last year. Pembrolizumab following chemoembolization, a phase 1 clinical trial, 3-month treatment duration, a small number of patients that were evaluable, but most importantly, basically did not demonstrate any added toxicity of the two. The combination did not yield, and no DLTs. So the rationale is still there. We can continue to investigate, and putting those two together does not increase the toxicity for patients. Dr. Sangro and the group reported the Nasir study, the phase 2 study at ILCA this year. Nivolumab plus Y90, a lot of interest of using Y90 in this patient population. Response rate of almost 40%. Pretty quick time to respond, but basically, again, no additive toxicity of putting the two together and basically forming the rationale and the baseline characteristics for continued investigation of Y90 and immunotherapies, including nivolumab. What are those studies? What is going on? Well, again, chemoembolization is the worldwide gold standard when you look at certainly intermediate disease, and now it's being combined with Durva-Bev, Pem-Len, Nivo, and Nivo-Ipi, as Dr. El-Khoury also described. So combining this with a standard of care, which is a local regional therapy, and of course cabozantinib is also in that last clinical trial there as well. So the rationale, of course, is to maintain the gold standard and add to it to see if you can increase and prolong PFS, improve response, and hopefully duration of response, as all the panelists have mentioned, and hopefully translate to an improvement in overall survival. So of interest, there is work that is being done with the use of electrical fields that can be used, and particularly in discussing, for example, HCC for this session, but all types of cancers will respond to electric fields of various frequencies. It will affect mitotic activity and cause cell death. And so there's a lot of work that's being done with this right now, and particularly in hepatocellular carcinoma. There already is regulatory recognition and FDA approval for GBMs, glioblastoma, and mesothelioma. So this is particularly novel and interesting. There is a phase 2 HEPANOVA trial that is going on now. You can see the apparatus is placed around the abdomen where the liver is located, and the patients are given this with concurrent sorafenib. The tumor treatment field is 150 kilohertz for the frequency for hepatocellular carcinoma, and the study is being performed on 25 patients with overall survival and response rate to see whether to proceed further. But very interesting sort of novel type treatments for HCC. Moving and continuing along the BCLC algorithm to the left-hand side in early stage, we know that the curative options in that setting are transplant, resection, and ablation. So what is the next opportunities for research in this patient population? Well, we know that transplantation is curative because not only does it remove the tumor, but the background cirrhotic liver that Dr. Singhal was talking about. And so in particular in the BCLC-B category, one of the hot topics is the downstaging concept that just because you have intermediate disease doesn't mean you could stage migrate to the left and be successfully downstage. And again, Dr. Singhal mentioned how these patients shuffle from side to side in the BCLC algorithm as things move along. And so potentially you can downstage them using size criteria or the UCSF or tumor volume, a model that's been designed by various centers. But the idea here is that you want to translate even patients classically not considered for transplantation down to transplantation and cure. Hepatic resection for select patients as well is something to consider, particularly those that have limited or no portal hypertension and without manifestations of, for example, thrombocytopenia or varices, etc. Patients that get hepatic resection in general have to have good liver function. And when you think about cirrhotic livers, the future liver remnant is considered 40% to be sort of the minimum that is required to perform a hepatic resection. The problem, of course, with hepatic resection is the recurrence rate. And this is where there's interest in this investigation. So first, how do you hypertrophy the future liver remnant? There is this concept called radiation lobectomy, where the atrophy-hypertrophy complex is identified, where the tumor is treated and the contralateral lobe hypertrophies in preparation for resection with promising rates of hypertrophy. And this is something that is used in hepatocellular carcinoma and now being expanded to other types of conditions. As I mentioned, recurrence is one of the issues that occurs after hepatic resection, even though it is curative. And we know that this is related to the size of the nodule, the number of nodules, the margin, of course. And this has been studied in the past with STORM in a randomized phase 3 trial to see whether adding sorafenib after resection or ablation would improve the gold standard endpoint of recurrence-free survival in that setting, and that was negative. But that doesn't deter anyone from performing in subsequent studies, and here in sort of very similar designs where patients that were resected or ablated, that is, applied a curative therapy with child class A disease, are now being studied in Emerald and Checkmate and Embrave and Keynote. And so agents like Durva-Bev, Nivo, Atezo-Bev, and Pembro are being utilized to see whether in the early setting, Child-Pugh A, BCLC-A, resected or ablated, we can improve on RFS. And of interest, actually, the overall survival is also included in Keynote 937. So 2 endpoints in that setting. What do we have so far? Has there been any work done? This is from Dr. Kassev at MD Anderson. That has a small cohort, I think, of a randomized cohort of nivolumab plus or minus IPI pre-resection. And effectively, the primary endpoint is safety to see whether this could be done. And interesting secondary endpoints of response rate, but the path complete response rate was identified in 24%. So a quarter of the patients had a complete response, complete path response at resection. There were, of course, some toxicities that you can see here and some surgeries that were aborted. But now you can see that path complete responses are being reported and probably will continue to be increasing report when we are looking at this setting here in patients that are either transplanted or resected. So to finish off here and look at a fifth case, this is a 62-year-old man with chronic HBV on treatment with compensated cirrhosis. Now undergoes HCC surveillance and is found to have a LIRADS 5 mass measuring 3.5 centimeters or so, good liver functions, ECOG performance status 0, platelet count normal, and the standard of care in this patient, if anatomically resectable, is for resection. So in this case, he underwent a robotic liver resection without complication, returns to clinic, and at this point, the issue is surveillance, how to surveil, whether to enroll in a clinical trial. And from here, I'd like to ask Dr. Singhal to comment on how we would address this patient.
Yeah, so Riyad, you mentioned that the liver resection would be a curative therapy. However, as you mentioned, this is associated with a very high recurrence rate. So this patient does need to be actively followed. And as you mentioned, that recurrence actually approaches 70% at 5 years. So it can be quite high in many of these patients. And so, what we typically do is that we follow patients with cross-sectional imaging every 3 months for the first year. And then we extend it to every 6 months thereafter. And they stay on cross-sectional indefinitely until the time of recurrence or something else. Now, as you know, if somebody recurs and they recur within criteria, they can actually undergo liver transplantation. And that's one of the key reasons to watch people so closely, is because if we can identify this early, we do continue to have very effective therapies. You also talked about many of the interesting clinical trials that are ongoing. And I think all of us have hope for in terms of the adjuvant setting. And so in our center, we do have an adjuvant trial, and this is somebody that we would approach for the adjuvant trial, discussing this high risk of recurrence. Now, I think that the question does come up. The role of immunotherapy is incredible, but there is this question of how does it interact with transplant? So if this patient went on a trial with immunotherapy, then recurred, could you still do transplant? And as high-volume transplant centers have had to think through, this post-IO world, many of us have come up with protocols that we basically would feel safe, transplanting somebody as long as that checkpoint inhibitor was held at least 3, if not 6 months prior to transplant. So, with the exception policies that are in place, typically, like somebody like this, we would, once again, offer a trial if it was available. If they recurred, we would evaluate them for transplant if they were within criteria. And during that evaluation, start to hold the checkpoint inhibitor and hopefully, list and transplant as eligible. Does anyone else what would you do at Northwestern, Riyad? Would you do anything differently?
I don't think so. I mean, this is something that's come up several times. I don't know whether, some people go from 3, 6, and go to a year, right away. I don't know if there's any right or wrong answer. And then we go to a year. Some people have pushed that back now to 2 years after a certain while. It's hard to envision some of these patients as coming back lifelong. They are cirrhotic. They do need to be maintained. And then, of course, you have to convert from scans, from MRIs to CTs to ultrasounds, of course. But this is something that's got to be monitored lifelong. I agree with you.
So we had, a lot of, once again, interesting data that have taken the checkpoint inhibitors not only in the advanced space, but started to bring them into the intermediate and early space. But I think one of the traditional questions that comes up, and it looks like it's come up again today from our audience, How do you determine when a patient should transition from local regional to systemic therapy? This concept of taste failure. How do you view that in your clinical practice?
Yeah, so I think the first thing is to highlight what I think you mentioned at the beginning of the session, which is the multidisciplinary tumor board, right? And so these patients need to be managed by the entire group, represented by this panel and others. And so my job then when I'm going to apply local regional therapy is to make sure I can maximize tumor kill, prolong TTP, duration of response, etc., but limit damage to the liver, because the more interventions the liver undergoes, the more there's going to be damage. And so in general, when I think about LRTs, particularly in early or intermediate stage, we will go 1 or 2 treatments to see how they respond, assess tumor biology, assess their tolerability, and then see and consider whether I'm able to get even more out of the local regional therapy, because there are some advantages to being off systemic therapies. Will they tolerate 1 or more, or is there a risk that they will now become decompensated liver patients? Because you heard the other panelists talk about Child-Pugh-A being a very important component of being able to tolerate the systemic therapy. I don't want to push a person into B7 or B8 or B9, as, for example, Katie was talking about. And so for me, I have to be careful that liver functions are monitored, that we minimize damage, and that we review them at tumor board. And the moment we think we've maximized the local therapy, we want to make sure that they still have good liver function to tolerate all the therapies that were discussed before, all of which mandate or need Child-Pugh-A status.
That's great. Anthony, Katie, anything else that you think of in terms of, in your multidisciplinary tumor board, something that you think that comes up in terms of this transition from local regional to systemic therapies?
Certainly, we tend to apply a bit more strict rules, especially when it comes to TACE, that, if a lesion or group of lesions have been treated with 2 TACE procedures without really achieving a CR, that we really consider that we've maximized the benefit of TACE. Now, this is specifically using drug-eluting beads or conventional TACE. I'm not talking about radioembolization. So we tend to transition to systemic therapy at that point, or to another local modality if there's only like a single 1 or 2 lesions. So it depends. I think I'd like to remind us all, though, that there are also other signs of progression, such as developing of portal vein thrombosis from tumor or extrahepatic disease. These naturally should lead to transition to systemic therapy. As Riyad alluded to, deterioration of liver function should lead to switch to systemic therapy usually. And I think he referred to biology as well, which is important. So someone who keeps popping up with new lesions in a multifocal fashion, you can only chase those lesions so much without deteriorating liver function. And these are patients should be considered to systemic therapy.
And I'll just add, at our multidisciplinary tumor board, we also look at some of these very same criteria in terms of liver function, the response to the individually treated lesions, whether it was a benefit or not, and also the pattern, as Anthony mentioned, including vascular invasion, but also one that we haven't talked about yet, which is sort of these diffuse or infiltrative tumor profiles, where we think that there's not a lot of arterial enhancement and generally, at least in some retrospective studies, poorer response to arterial therapies, and they tend to poorer prognosis. So often an infiltrative or diffuse type picture, when suspected, will transition earlier to systemic therapy, just like with vascular invasion.
Yeah, I think, it's interesting because I think all of us operationalize this just a little bit differently. But I think the common theme that you're hearing across all 4 centers is that we've moved away from the traditional, you need to have metastatic disease. You need to have vascular invasion to be considered for systemic therapy. I think all of us are becoming much more cognizant about taste failure and the role of systemic therapy for some patients who have failed local regional therapy, even though they continue to have liver localized disease. Yeah. And so I think that's the big thing, is that really, as we've seen dramatic advances in the systemic therapy space, is that we want to give people the benefit of actually receiving them if and when possible. And so it really, once again, as Riyad mentioned, this really has to be continue to be a close conversation between everyone at the table to find out when this appropriate transition occurs. We had another question that came in. You brought up the 6 and 12 criteria. Once again, I don't think, all of us necessarily use that specific criteria, but it does bring up the question of what do you consider for multifocal bilobar HCC disease? The case you presented, was I think like a 6.5 centimeter lesion, once again, squarely in local regional therapy space. How do you determine the role of local regional therapy for these patients who have multifocal bilobar HCC?
So I think trying to answer that question, you can't avoid the concept of categorizing or subcategorizing the BCLC-B patient population. So the reality is probably 80% of the BCLC-B patients that we see are what I would call low Bs, close to the As. And those patients do pretty well. There's level 1 evidence on this. We treat them. When they develop metastases, we migrate to systemic therapy, etc. I would say that the multifocal bilobar HCC, however, is very difficult to treat because we don't disagree with Anthony's comment about 2 chemoembolizations or radioembolizations, but it's very hard to achieve that for the entire liver when you have multifocal bilobar disease without risking hepatic decompensation, at which time the patient may be unable to benefit from all of the advances in the systemic therapies. So I'm a little less enthusiastic about the BCLC-Bs that are close to the Cs because they have multifocal bilobar disease. So that's the patient population, in my opinion, where I think consideration for systemic therapy earlier, or to Katie's point, almost sort of the infiltrative appearance of so many lesions, makes a lot of sense because it's theoretically very possible to have them decompensate following some form of local regional therapy. So I'm less enthusiastic of local therapies for the multifocal bilobar disease and more excited about the type of research that we heard about today.
And we had, sort of outside the textbook here, but sometimes for these bilobar multifocal patients, do you do combos? Do you, consider a radioembolization and then starting systemic therapy shortly thereafter? So, not one or the other, but
absolutely.
But, really starting to think ahead of the curve in terms of combining these.
Absolutely. So while the clinical trials are nice to have and doing things on protocol is nice to have, the reality is all of the patients are going to get some sort of combination off trial, probably. If you look at the statistics, most people are getting some sort of combination. And the combination is, as you mentioned, 30 days later, 45 days later. So I agree with you that what I'd like to do, if I can treat somebody safely with, patient with BCLC-B that maybe is a bit more aggressive, if I'm going to apply local regional therapy, this is the kind of patient where I want to start systemic therapy quickly, day 30. Let them resolve their adverse events from the LRT, the local therapy for a month, and then start systemic therapy early. I completely agree with you. Even off trial, of course, because most stuff is going to be done off trial. But many of these therapies, including the immunos, have been shown to be so safe now, even now with mild liver dysfunction, that you can't help but try to now squeeze these 2 treatments together to maximize the benefit for the patient.
Yeah, I think, similar to the advanced space, as we start to have more of these concepts come to mind, there continue to be questions that we need to answer. Really operationalizing taste failure, operationalizing what's the best timing and patient for combination therapies. I think, as you brought up, very important questions as we move forward. So we can take what we sometimes do in clinical practice and really know what the best practices are in the future. So hopefully these trials do come to market soon, and we can start being quote unquote smarter with our approaches for these patients. So, I'm going to end where we started, really, once again, talking about the, multidisciplinary care and how hepatology fits into this. I think that, we've seen an expanding role, for medical oncology, definitely, as you've seen during the talks, both in terms of the expansion of oral therapies as well as the expansion of immunotherapy. And we've already seen a very large space for local regional therapies. And so, there have been, centers and people who ask, so how do hepatologists fit into the management of HCC? And some of these things are obvious. Like for example, we do the screening. So we're the ones who often are taking care of these patients. And they start in our clinics. So we're the ones who are performing screening. We're the ones who are often diagnosing the HCC, and having to educate them about their liver disease, their HCC risk. And often we're the first person who sees them when they're being diagnosed with HCC. So all of these concepts of communicating effective therapies across the spectrum, prognoses, that often starts with the hepatologist. Now, of course, even after a patient is diagnosed with HCC, I have a strong feeling that hepatologists continue to fit into that paradigm. I think of us as the quarterback for the multidisciplinary teams. We don't do any of the treatments per se, but we do help organize the team. We help develop a personalized treatment plan because, once again, we often know that patient the best, their priorities and their preferences, and we can help actually organize when people transition from one therapy to the other. So as patients may transition from an interventional radiologist to a medical oncologist, or as people transition to the left-hand side of the slide, from systemic therapy to local regional therapy, and thereby, once again, being considered for curative therapies. Of course, many hepatologists also are transplant hepatologists, and once again, ending where we started, transplant continues to be the best cure and the best treatment for HCC long-term. This is a cure not only for the HCC, but a cure for cirrhosis, provides the best long-term survival. Finally, of course, we have to continue assisting with management of underlying liver disease, managing disease and treatment-related AEs. So many of these patients we've already talked about have chronic liver disease. If they have viral hepatitis, they should be considered for antiviral treatment. If they have immune-mediated hepatitis, we're often the ones that get called and help manage those AEs. And then, of course, as I said, we have to educate patients about all of the treatment options, including clinical trials. We've seen a lot of progress over the last several years, and we've seen the prognosis dramatically improve for HCC across the spectrum. But we continue to have exciting clinical trials that are coming about, and we must continue doing good science to continue pushing the field forward. So overall, once again, I'm biased, but I do think that hepatologists play a very strong role in the management of patients with liver disease and patients with HCC. So with that, I'd like to thank my panel. I thought it was a very exciting conversation, just really great presentations. Honored to be on the same, webinar or virtual platform with them.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/CWP860. This activity is supported by independent educational grants from AstraZeneca, Bristol Myers Squibb, Exelixis Incorporated, Merck & Company Incorporated, and Novocure.